another way, sometimes surgically, it's treated is by a canaloplasty or meotoplasty. That's when the canal is it's widened, so the rest of the ear canal is widened so it matches the widening themselves. So you're getting rid of any craters, bumps, potholes, if you like, widening. So it helps with the natural migration of skin. So there's different potential causes, and therefore for the different causes there's different treatments. I think I've seen one patient undergo a surgery before for keratosis obturans, and I know that there's a few ENT consultants who would recommend not persistent use, but say monthly or bi-monthly use of anti-inflammatory drops. Because once you're prone to this condition, it can be a chronic condition, so you use an anaesthetic. Now, for anyone who doesn't know what keratosis obturans is, I'm going to explain it, but I've also got a playlist on my YouTube channel. So do feel free to visit my YouTube channel, and you can search by entering Wax Whisperer or the Hair Clinic, or just enter my name and my wife there, and you'll come across my YouTube channel. Of course, many of you are already watching on YouTube. And then if you navigate to my playlist, I've got a whole playlist of keratosis obturans cases. So keratosis obturans is a build-up of dead skin, essentially. It's a dead skin plug. It can often be confused for earwax because it's got a similar appearance. Other than a patient presenting with severe pain, another giveaway with keratosis obturans is, well, a couple, is the location. It's mainly in the deeper portion of the ear canal, the bony part, and it's the texture. It is essentially equivalent to a rubber ball. It's got this springy texture, and that's because it's made up of dead skin sheets, and this dead skin sheets, it falls over itself, and it has so much collective energy that when you attempt to remove it, it can spring back. Now this keratin, it continues to grow in the ear, and the plug gets bigger and bigger to the point where it starts to create a physical change in the ear canal itself. It widens and expands the ear canal, both due to physical pressure exerted by the plug up against the bony part of the ear canal. But another reason is that sitting on the bone surface, remember the inner 2/3 of the ear canal is made of bone, the outer third is made of cartilage, and sitting on the bone portion of the ear canal is a small thin sheath called periosteum, and that supplies the bone with all the blood and nutrients that it requires to sustain itself. But by applying pressure onto the periosteum, you can cause inflammation of the periosteum and possible periosteitis and infection of the periosteum, and that initiates a process called bony reabsorption. Bony reabsorption is when bone cells called osteoclasts sitting on the surface of the bone, which is initiated by the inflammation of the periosteum, begin to break down bone tissue. You also have another type of cell that sits on the bony part of the ear canal called osteoclasts, and they perform the opposite duty. They help bone to regenerate itself. But in the case of keratosis obturans, this epidermal skin plug is forever growing and expanding, and it's compressing against the ear canal wall. That physical pressure can cause the bone itself to widen, and you probably mentioned it, but I forgot if I have already. I apologise if I did. The bone that encapsulates the bone part of the ear canal is called the temporal bone. It's regarded as the second strongest bone in the body behind the femur bone. So you can just imagine the physical pressure and force that's required to widen and remodel the bone. And that's what, of course, causes the patient with severe pain. But in addition to that, the compression of the plug against the canal wall causes irritation and inflammation of the periosteum, which then initiates cells that live on the bone surface called osteoclasts, which are involved in the breaking down of bone tissue, which then causes a remodeling of the bone itself. And the widening of the ear canal with keratosis obturans, it's what we call global. It occurs all the way around circumferentially, so it's equal all the way around the periphery of the ear canal wall. It's not localized to a specific point. You may get some regions that are more widened than the other, and these widenings are quite smooth, unlike other ear pathologies like benign osteonecrosis or a canal keratosis, where you get specific parts of the ear canal that are widened. They are quite rough and jagged. With keratosis obturans, the widening is quite uniform and global. You get 4 different grades of keratosis obturans. Grade 1 is when you attend with mild pain, but there may not be much evidence of widening of the ear canal. The grade 2 is moderate to severe pain, which is what this patient attended with, and you get mild to moderate expansion of the ear canal, and of course a conductive hearing loss because this patient's not able to hear because of the skin plug. A grade 3 is similar to a grade 2, but you get moderate expansion of the canal wall, so it's more obvious. But an important hallmark of a grade 3 keratosis obturans is the presence of granulation tissue. Granulation tissue is inflammatory tissue, and it's made up of connective tissue. And this connective tissue undergoes a process called neovascularization, where it forms its own blood capillaries. Therefore, quite often with a grade 3, when you remove the keratosis obturans and you disrupt the granulation tissue, you get bleeding because all these newly formed blood capillaries are ruptured. So we call that contact bleeding. And a grade 4, I've never come across one, I don't think, is when the expansion is so severe that the back of the ear canal wall merges with the mastoid bone. So it looks like they've got a mastoid cavity. We call it an automastodectomy. So it's a really, really severe expansion. It can sometimes affect the facial nerve, so it can cause facial paralysis, and sometimes in really, really severe cases, this keratin plug can grow upwards, and it can cause a dehiscence, so a breaking down of the tegmen tympani bone, which is the bone that separates the intracranial compartment to the middle ear. So that can be quite a severe, possibly life-threatening occurrence. Now, I've never come across that, but it is mentioned in the literature. In terms of incidence rates, how common is this procedure? Condition, and therefore procedure? It is approximately 4 to 5 in 1,000 cases of patients who attend ENT audiology. For comparison, a canal keratosis, which I've uploaded several videos of late, is 1 in 1,000, so this is 4 or 5 times more common than a canal keratosis. So canal keratosis are quite rare. Interestingly, keratosis obturans is more of a younger patient condition. It's very seldom you see it in older patients. So patients between the age of 20 and 40 are more likely to develop this. It can just occur unilaterally in one ear, but equally it can occur in both ears. So I would say in my experience there's probably more unilateral cases, it's in one ear, but the literature states that it's 50-50 in that case. And what causes it? So there's several causes that are known. It's not fully understood why people develop keratosis obturans, but for us to understand, we need to first of all understand the anatomy of the ear and the physiology. So the ear canal is lined with skin, so is the outer layer of the eardrum, and as the skin reproduces itself, we call that daughter cells. The daughter cell pushes the older layer of the parent cell of the skin upwards, and this skin cell has to travel 5 layers to reach the surface of the ear canal. And when it's at the surface of the ear canal, it's furthest away from all the blood supply at the base of the layer of skin, the epidermis layer, which is made up of 5 layers, and therefore the skin dies. And when the skin dies, it fills with keratin, and the skin should slowly migrate out of the ear. It's like a conveyor belt. So your ear produces the skin dies, replaced by another layer of skin. That dead skin slowly but surely makes its own way out of the ear like a conveyor belt at a rate of about 1.5 to 3 millimeters a month, so the equivalent to your fingernail growth. And it should just naturally come out of the ear. For Keratosis obturans, one of two things can really happen. You can have an excess amount of dead skin that forms in the ear, and that's quite often due to chronic inflammation. If you've got chronic inflammation of the ear, it promotes self-proliferation, so increased number of skin cells, which of course then die, and the skin falls into a plug. Another potential cause is, going back to the chronic inflammation, when you have that, the skin migrates, but it doesn't migrate out of the ear. Instead, it migrates inside the ear, inwards to the midline, and that then forms into a plug. So they're the most common causes. It's just an increase of dead skin collection, or the skin doesn't naturally migrate out of the ear as it should. Instead of going outwards, it goes inwards, and these are typically caused by chronic inflammation of the ear. So patients who suffer from eczema, psoriasis, dermatitis, a little bit more prone to developing Keratosis obturans. Sometimes trauma to the ear canals, so if you're poking in your ear, you scratch the ear, that can initiate the chronic inflammation. So there are several causes there. Now, I appreciate and I apologise that in terms of visuals, some of you may not like this video because these are long hair strands and how narrow the ear canal is. It's just unavoidable. This is what I'm presented with in clinic and what I have to deal with. So I do apologise, but this is part of the job, really, being able to remove it in these conditions. It's not warranted you to cut these hairs. In fact, plucking or cutting these hairs can lead to folliculitis. Folliculitis can then lead to a furuncle forming, and a furuncle, so it's like a full pimple, swelling in the ear canal, and a furuncle, furunculitis they call it, so the formation of the furuncle is also a known cause of Keratosis obturans, so it's a self-fulfilling prophecy, right? These hairs could actually end up causing Keratosis obturans, which obviously we don't want. Now, just using the Jobson horn here, just slowly bringing it forwards. I was constantly just checking with the patient they're okay. There were times where the patient was experiencing pain. More so when I was using the suction, they found that a bit more uncomfortable. So I'm trying to remove as much of this with the Jobson horn. You can see that I'm using metal instruments in this case. And with Keratosis obturans, I generally find the metal instruments a little bit more efficient because it's so difficult removing this plug. Unless you, I'm sure loads of audiologists hopefully may be watching this and they'll fully appreciate Keratosis obturans and the difficulties associated with it, and just feel like the metal instruments just provide a bit more force and pressure to extract and pull this out of the ear. So in a minute you're going to see the widening. Just going to peel some more dead skin away. You can see that widening to the right, that's quite visible, it looks a bit tender and traumatised there. Just a bit of dead skin inferiorly to the eardrum. In terms of treatments, most commonly it's just regular cleaning of the ear, or poking inside the ear. If you've got any chronic inflammation, this is the underlying cause, we need to deal with that. Some patients are prescribed anti-inflammatory drops, which helps reduce inflammation, which then reduces the development of dead skin in the ear, forming into a plug, and the abnormal migration of the dead skin, the epithelial migration. Sometimes you can have split skin grafts, which patch up any widenings. Because once you've got a widened ear canal, you're then more likely to get Keratosis obturans because the skin can't migrate out of the ear efficiently because it enters the widening and sometimes it can't escape. So by patching up those widenings can sometimes help. On the other hand, another way sometimes surgically it's treated is by a canaloplasty or myotoplasty. That's when the canal it's widened, so the rest of the ear canal is widened, so it matches the widening themselves. So you're getting rid of any craters, bumps, potholes, if you like, widening. So it helps with the natural migration of skin. So there's different potential causes, and therefore for the different causes there's different treatments. I think I've seen one patient undergo surgery before for their keratosis obturans, and I know that there's a few ENT consultants who recommend not persistent use, but I would say monthly or bi-monthly use of anti-inflammatory drops, because once you're prone to this condition, it can be a chronic condition, so